But in the military, what happens is they will have clinical practice guidelines. So actually, one of the really, the Institute of Surgical Research where I work is really a unique place and really a wonderful place to work. And I hope everyone thinks that of where they work. But the reason why I believe that is because we have a mix of MDs who are treating the patients, and they're allowing us to determine what the actual issues are. Then you have the PhDs who bring the research and the scientific method combined. And then we also have the Joint Trauma Center, which has the registry of all the injuries throughout the war. So we actually have the data, the injuries, what happened, and then we're looking at doing studies to figure out what the outcomes are. So which injuries, which patterns, what treatments resulted in favorable or non-favorable outcomes. And then the ones that are really bad, that's where our research gap areas where we're focusing on. The other thing about the JTS is that they have the clinical practice guidelines. So all inside one institute, we can get these clinical practice guidelines, which are written and then distributed, and they're available for anyone. And they're very short, if these are what the recommended is. And so people don't have to go in and scour through thousands of journal articles or books to figure out. It's a one-stop shop that basically says these are the recommended guidelines for these types of injuries. There's an entire field of practice called basically translating research into practice, and most discoveries on the outside takes up to 17 years on average from discovery to actually being in practice in most places. And we're trying to speed that up considerably. Sometimes the injury is so severe you cannot salvage the limb. And I think we are not anywhere close to being able to grow a new limb, like a salamander does, because our biology is just not the same. However, the prosthetics are improving, and whether or not and where the injury is on the limb matters a lot. So if the person's what they call a BK, or below the knee, the outcomes are much better because they have the knee joint to be able to help in locomotion. If they're an AK, above the knee, it's not as good. So the hope is of the limbs that we can salvage, we do, and it has a favorable outcome. And then there's an entire other discipline, a completely different discipline that we talk, we see, but the day-to-day activities are very separate. And what they're looking at is, that's the prosthetics and the physical rehab on how to take care of these patients the best. And that's, when I say we talk and we're close to each other, that's right across the parking lot here, the Center for Intrepid is 100 yards away. And so we get to meet on a regular basis and hear what they're doing and what they're up to and what they're focusing on. And so we can complement but not overlap. Absolutely. So the regenerative medicine, tissue engineering, regenerative medicine phase that we're working on is just not even the tip of the iceberg of what's going on in the civilian sector. Think about if they can regrow the beta cells in the pancreas. Everyone who has type 1 diabetes would be able to produce their own insulin and could live. There's thousands of patients that die per year waiting for kidneys or liver, heart, and so if you could regenerate that, it would help many patients and families. We're on the trauma side, not the either disease or congenital defect side. So although they're complementary and they work together and they use a lot of the same principles, they are distinct. I think it depends on what part of what we're working on, the portion of the clinical trials. So what we're trying to do is have a research program that has near-term, like immediate results. Once we know what the answer to this is, it can be translated quickly into practice. And an example of that is the clinical studies of existing devices to see what works best in our patient population. The challenge there is coordinating these large studies. And although open fractures and amputations are common, there's not tons of them in one center. And so since you need so many patients to actually, because it's so variable, to actually find what the truth is, the challenge is finding funding, getting funding steered to that, and then actually doing these studies. And it can take up to 5-7 years to figure out which treatment is best. And then if you look into the emerging preclinical studies, where we're using preclinical models that as technology is emerging, they're mature, meaning they could go into the FDA pathway within the next several years. The other challenge is these are challenging preclinical models, and actually down selecting which ones we should invest in. On the basic science aspect, from regenerating the tissue, a lot of these things are very complex and complicated. And although if it works in a laboratory on regenerating tissue in a small model, maybe a centimeter by a centimeter, how do you translate that into a human scale? And then the other aspect is the things that work the best may not have a clear FDA pathway, meaning that they've never been used before, and everything has to be going through, each portion of it. And you have to sometimes demonstrate that everything that you add. So for example, if we're going to add a bone graft that releases antibiotics while growth factor, we have to show that that the antibiotic helps. And to do this, it may be hundreds of millions of dollars for the actual clinical trial. Now we, the military, generally never pick that up. What we try to do is we have the discoveries, we put in an invention disclosure, and hopefully that we carry that to a point where a company is excited enough and believes it enough that they will license it and then take it further. That's kind of one of the paths. And then the other pathway is actually using the military structure and system to move it into advanced development. So there's a couple different paths. I think the funding for this increased tremendously over the past decade. And it's because we were getting thousands of patients who were being medevac, and it was made that this is a priority, and during this, hopefully the next 12 years, hopefully will be peacetime and we get no more casualties. But the issue is we now understand what the problems are. What are people suffering with? And we can focus the research to translate, to find medical solutions for them, whether it's a new product, a drug, a device, or just knowledge to create these guidelines to improve the outcomes. So I think if the funding level remains robust enough for us to continue down this pathway, I think that a lot of the things that we have in the pipeline will be transitioning into clinical studies, or we'll actually have completed them, and there'll be guidelines that are in place for the next war. If the funding dries up, it decreases tremendously. I think that that will be, stalled, and then the field will just keep moving on. The leadership has done a great job on setting up a system to where we create what we call capabilities. And a capability would be the ability to restore function to somebody who has a limb salvage. Then we do a gap analysis and we figure out where we are now and where we want to be. And then within that gap analysis, then you can have the research topics that address this gap, and hopefully we'll move where we are now and close the gap, if you will. I think what we have to be is very disciplined to stay on those priorities. and not start wandering into things that just are a personal interest. And so I believe that we have that in place. The third thing is our ability to continue to recruit very good people. I think probably our best asset is the people that actually work on the problems. And with the war drawing down, I think our ability to continue to recruit people to come in, because it's cyclical. People, they retire, they leave for other jobs, they come in as a postdoctoral fellow and move out. It's just part of the nature, but our ability to continue to get people.